Here's our next section of neurology, and this guy is sticking his tongue out at me. At least he's trying to stick his tongue out at me. What do you do? Don't stick your tongue out at me. You see, the whole problem is this guy's trying to stick his tongue straight out at us, but he can't do it. Why is it deviating? This abnormality is an abnormality of the 12th cranial nerve. The most accurate test for cranial nerves is always at the MRI, the most accurate test. Now this guy is cranial nerve 12, and it always pushes to the weakest side. So which of these is weaker? The weaker side is on his left. It pushes towards the weaker side. Pushes towards the weaker side because the 12th cranial nerve should have the tongue pushing straight out. So this person, the left, is weaker and it pushes over. Left is weaker and it pushes over. Now this is a defect of the 12th cranial nerve on his left, and when the tongue is extended, it deviates towards the abnormal side because the abnormal side is weaker. There's a defect of the 12th cranial nerve, and the weaker side can't extend, so the stronger extends more. Because it is the 12th cranial nerve, and cranial nerves are brainstem, MRIs are the best test for looking at brainstem. Cranial nerves all originate in the brainstem. Oh, wasn't that disgusting? Yes, it was. Next one. Remember, 12 cranial nerve defects deviate towards the defect. Your tongue points towards the defect. Your tongue points towards the side with the defect. Cushing's reflex. Now, Cushing got around. Cushing is basically the father of neurosurgery, invents neurosurgery. He was a student of Sir William Osler. He's at Johns Hopkins. He's responsible for bringing the blood pressure cuff to the United States. I mean, he really promulgated the blood pressure cuff in the 1930s. And Cushing's reflex was a sign of intracranial pressure increase. It indicates that you've got usually head trauma, serious head trauma. Cushing's reflex is bradycardia and hypertension. Bradycardia and hypertension, and the first thing you should do is get a CAT scan of your head because it's a sign of increased intracranial hypertension. Bradycardia and hypertension. Now, Cushing's reflex is an indication that you're about to herniate. Massive increase in intracranial hypertension, and it shows you that there's an expanding mass lesion or hemorrhage inside that brain. So it means that you need to get inside that brain and suck out the pressure before you herniate and die. Now, before there were CAT scans, people used to really have to pay attention to things like Cushing's reflex, because how else would you know? I mean, how else would you know that the lesion's in there? How else would you know that there was something else in there that means that you're about to herniate and die? I mean, how would you know about that? You wouldn't have any way of knowing about it unless you had a scan. So before scans, we used to have much worse intracranial hypertension. Can you imagine that you didn't even know it was there because you had to operate on people's skulls without being able to visualize inside? Can you imagine the guts it must have taken? No wonder people used to think surgeons were God. Oh, sorry, somebody here going into surgery? Like a surgeon, cut for the very first time, because you have to crack people's skull open, and what if it wasn't there? Cushing's reflex, increased intracranial pressure resulting in bradycardia and hypertension. Scan me, drain, next card. The deep tendon reflexes. So when the deep tendon reflexes are assessed by hitting with hammers, patellar ankle, and where are they? This is the other thing. What nerve roots correspond to which of these deep tendon reflexes? Which nerve roots? Oh, hyperreflexia, cord compression. Hyperreflexia, cord compression. Hyporeflexia, thyroid, thyroid, thyroid. What do we got?
We're now going to test reflexes and start with the knee jerk. Just relax totally. here to the other side. Good. And we're going to now test the ankle jerks. Just relax. Just totally relax. To position it. Good. And we're going to try the other side. Again, just totally relax. Very good.
So that's showing you some of the deep tendon reflexes. The patellar reflex is assessed by tapping that hammer just below the kneecap when you're seated. It has to be seated because you can't have any pressure on the leg. If there's pressure on the leg, you won't be able to have the reflex. The ankle reflexes, the patient is having the knee on a chair and upside down. You have to put your knee up. You have to put your knee up like that. Put your knee up. You can't see it. So basically, the ankle reflexes is assessed by putting your knee up. Oh, here I am. I'm acting on all the reflexes. Wait till we get to priapism. Okay, so you're putting your knee up. The ankle reflex, so the leg is hanging out in the back with ankle reflexes, so it allows the ankle to move. Free movement of the ankle. The patellar reflex is L2-4. Patellar reflex L2-4. Ankle is S1-2, naturally lower, right? Ankle is S1-S2, naturally lower. Yes, it is. And the triceps, 6 and 7, 6 and 7, 6 and 7, 6 and 7, C6, C7. So patellar, L2-4. Ankle lower down, S1-2. And triceps is 6 and 7. The outside of the hand. The outside of the hand there is C6 and 7, C7. The outside of the hand, the pinky finger is C7. Hyperreflexia is associated with cord compression and CNS disease. Hyperreflexia. Cord compression and CNS disease. Squeezing on that cord results in hyperreflexia. And that's an unopposed upper motor neuron reflex arc, lower motor neuron reflex arc. Hyperreflexia is by cutting off influences from the upper motor neuron. When you cut off the influences from the upper motor neuron, you tend to have hyperreflexia. Now, when you have a loss of inhibition of those motor neurons, that's why things end up exaggerated. So you could say it's cord compression or a cord cut that makes hyperreflexia. Now, reflexes are diminished when there's just simply loss of sensation, or you directly damage the area of the spine that the roots are going into. When you directly damage the area of the spine where the roots are going into, or when you have thyroid problems that give you a delayed relaxation. In other words, thyroid, you hit it, that's hypothyroidism, hung reflexes, one of my great phrases. Here we go, the triceps, C6-7, C7-8, triceps reflex, triceps. 2-3-4, 2-3-4 is patellar. S1-2, S1-2 is ankle. Here we go, what is it?
Now, I want you just to relax your hands, and I want you to tap on one side as fast as you can. Now I want you to go ahead and count down your fingers and come back up and keep going up and back and down. Good, other side, just tap first and thumb. And now go down and count your fingers, coming back up. Very good. I want you to shake your hands and flip off water. Now make a loose fist. Bring your arms like this. Now rotate your right wrist back and forth and the left wrist back and forth. Now what I want you to do is I want you to pat your leg and go front, back, front, back, front, back, and just keep going as fast as you can. Other side.
I can't even pronounce that word. Dysdiadochokinesis? Is that choledocholithiasis? Dysdiadochokinesis? What does that mean? It means I can't do rapid alternating movements. Flop, 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 flop. You think that? You see, that thing about rapid alternating movements, that's more difficult than you think to be able to do that. To be able to do this, there's more that goes into that than you think to do rapid alternating movements. Rapid alternating movements has a great amount of depth to it to have the patient hit the thighs rhythmically, flopping it over. flopping it over, palm and back, palm and back. There's a lot that goes into that. See, when you rapidly touch the thumb and the fingers in succession, that is much more complicated than you think, because this can be from, when it's damaged, you have it from a cerebellar stroke. It's from lesions of the cerebellum, things that decrease the stimulation of the cerebellum. The most accurate test, because it's a cerebellar lesion, is the MRI, because when we're looking at the cerebellum or the brainstem, we need an MRI. When we're looking at the cerebellum or the brainstem, from the cerebellum or the brainstem, we need the MRI. CT scan is the best way to look for blood, but CT scan is not the best way to look at the cerebellum. CT scan is the best way to look for blood in the brain, but not the best method of looking at the cerebellum. Dysdiadokinesis, rapid alternating movements, cerebellar lesions. So, tremor. A tremor, when it's both rest and exertion and tension, that's an essential tremor. Both rest and exertion, both rest and exertion, that's an essential tremor. When you have a tremor that's only at rest, that's Parkinsonism. When you have one that's only with exertion or reaching for things, that's ataxia. The difference between these tremors: essential tremor at both rest and reaching for things. Parkinsonism is only at rest, 3 cycles a second. Ataxia is only when reaching for things, because like a finger and a nose. What worsens an essential tremor? Essential tremor is worsened by anything that's a stimulant. Essential tremor is worsened by anything that's a stimulant, like caffeine, cocaine, or alpha agonists or beta agonists. So essential tremor is worsened by stimulants. There is no diagnostic test for essential tremor. There's no diagnostic test for Parkinsonism. Even ataxia, we can scan the brain with an MRI and look at the posterior circulation. For ataxia, look for posterior circulation. Look for the brain stem. Look for the brain stem. Look for the posterior circulation. But most tremors are just diagnosed by having tremors. Essential tremor is all the time. Parkinsonism, just at rest. Ataxia, just with exertion, just with intention. What do we got here?
I now want you to put your hands straight out in front of you. Stretch your fingers out wide and press like you're pressing very hard, looking for any evidence for any type of tremor. Very good.
So the essential tremor is both times rest and with intention. Beta agonists make it worse. Beta blockers make it better. Caffeine makes it worse. Beta blockers make it better. Essential tremor. Now, Parkinsonism is only at rest, and it decreases with giving medications for Parkinson's disease, like levodopa, carbidopa, or pramipexole, ropinirole. Parkinsonism. And ataxia is a tremor that's only when you reach for things. And believe it or not, it's actually the least noticeable at rest, because ataxia is only happening when you reach for things. That's when ataxia is the problem. Essential tremor gets worse with all stimulants, including hyperthyroidism, because remember that hyperthyroidism is part of beta agonist, beta stimulation with hyperthyroidism. Now, essential tremor, is it true? Essential tremor, like you stop your hands from shaking by having a drink of alcohol? The answer is yes. You stop a hand from shaking from having a drink of alcohol. And ataxia, you get an MRI, but there's nothing you can actually do about it if it's a stroke of the brainstem or stroke of the cerebellum. You diagnose it, but there's nothing you can do about it. All you can do is just be sure it's not something else. Because there's no specific test for Parkinson's. There's no specific test for essential tremor. Parkinson's disease does not have a test. Isn't that the most amazing thing? I think so. Oh, what do we got here? Expressive aphasia. I have a hard time expressing myself. I have a hard time speaking. Well, like, what is an expressive aphasia? Well, what the word says, I can't Well, it really is brillig in the slivey toves, is gyring and gibbling in the wave. The jabberwock is a small snicker snack with this vorpal blade. Don't you understand me? How is it evaluated? By asking people to express themselves, either in writing or words. Sign of a stroke. And the most common cause, well, let's look inside expressive aphasia.
I'm going to show you this picture, and I want you to just look at it and tell me what you think that picture depicts.
This looks like a mother and her son, and they're playing together, and she's giving him a piggyback ride, and they're laughing and having a fun time together.
Very good. Now what I want you to do is to write a sentence about that picture. Very good. And she wrote, a mother and a son are playing together. What I'd like you to do now is to just read this paragraph. We're going to put your reading glasses on, that's fine. And just start right here and just go ahead and read until I tell you to stop.
When people feel ordinary anxiety, they are usually thinking about something bad that has happened or could happen. Those thoughts seem to offer reason enough for the anxiety, but sometimes nervousness lasts a long time, becomes overwhelming, or starts to affect daily activities and relationships. At that point, it's time to think about whether an anxiety disorder is part of the cause.
Okay, very good. So what was this paragraph about that you read?
Anxiety.
Okay. And what are some of the things that would indicate that there's a problem with anxiety?
If things that you're worried about interrupt your daily activities or your relationships with people.
Very good. What is this?
A pen.
And what do you do with it?
Write.
Good. What is this?
A watch.
And good. And what's this part of the watch?
A stem.
Very good. What would this be?
A ring.
Very good. And what would this be?
A tie.
Good. Can you repeat this sentence to me, or for me? No ifs, ands, or buts.
No ifs, ands, or buts.
Very good.
Expressive aphasia is a Broca's aphasia. The patients can't speak or write clearly, and they get frustrated because they know what they want to say. They're trying to say it, and they just can't get it out because Broca's area is screwed. Pronouns and prepositions are, so you say to people, no, can you repeat after me? No ifs, ands, or buts. Okay? Pronouns, prepositions, and conjunctions are omitted. I know what you might be thinking. You might be like, that, do, I. That, do. So speech is hesitant and labored and difficult because it's non-fluent, because you can't express yourself and you're pissed off. So comprehension means that I can understand what you're saying, but I can't get the words out. Comprehension means in a Broca's aphasia that receive, meaning try, speak, not clear. Damn. That's Broca's aphasia, okay? So what do is you evaluate it by asking the patient to speak, okay? Asking the patient to speak and write in complete sentences. And in handwriting, okay, if the handwriting intact, the words may not be intact because it's just like a non-fluent aphasia. You can say individual words, you can write individual words, but the content of the words is not intact. And they can't repeat the phrase, no ifs, ands, or buts. Say that word. Now, expressive aphasia, Broca's aphasia, is generally speaking a sign of a stroke. It's a sign of a stroke of what part of the body? The temporal and parietal areas. Expressive aphasia. Head CT, MRI, head CT and MRI, head CT and MRI. And Broca's areas in the left temporal area, Front, now where the temporal lobe hits the frontal lobe. Boy, that sucks. Finger to nose testing. Oh, that's an easy one. See, Broca's aphasia, after you screw that up, okay, finger to nose is simply a cerebellar disorder. Finger to nose, exactly what I said. Touch my finger, touch your nose, and touch my finger, touch my nose. And the most common cause of abnormal finger to nose is damaging your cerebellum. It's a posterior circulation problem. And since it's posterior circulation, the most accurate test is an MRI. Because you're looking for posterior circulation.
What I want you to do now is to make a pointer out of this finger, go from the tip of your nose, the tip of my finger, back and forth. Okay, now I'm going to go out further and move. Good. Other side. Go a little bit further and move back and forth. Very good.
So finger to nose testing is assessed by touching your own nose, reaching for the examiner's finger as quickly, faster, faster. And what will happen is that people will reach past it and pull back. They'll reach past it and pull back. They'll reach past it and pull back. So that's how you assess an abnormal finger to nose, by asking you to do it fast. And then you try it also with your eyes closed. Because look, I should be able to touch my finger. Hey, I feel it. 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 See how I can touch my nose, my finger, my nose, my finger, my nose, my finger, and it goes faster and faster. I should not lose it. I should not lose it. I should not lose it. That's finger to nose testing. Okay, the finger to nose testing, you shouldn't lose the ability to touch someone's finger and your nose, even if your eyes are closed. Because the abnormalities are basically when a patient overshoots the target and you can't touch the examiner's finger. You're missing it. You're missing it. I'm going to touch it. I missed it. And this past pointing is a sign of cerebellar disorder, because you should, with your eyes closed, be able to touch a finger even with your eyes closed, even with not looking. Not looking, I'm not looking, I'm not looking, I'm not looking. And past pointing is a sign of cerebellar disorder. So when you can't control this movement, when you can't control these muscular acts, it's called dysmetria. And that's when you can't control these muscular acts. Now, the tremor is not relevant. See where it says tremor can accompany the abnormality? Yes, it's true. You can have a tremor accompanying the abnormality of an abnormal cerebellar test, but it doesn't change anything. Because even though you say, I'm past pointing, I'm past moving, I'm moving the wrong way, it doesn't change anything. Now, the most accurate test of a cerebellum is looking at the MRI of the head, because the cerebellum is not seen well on a CT scan. CT scans look for blood in the brain, but they don't look at the brainstem CTs, and they don't look at the cerebellum. For posterior circulation, you need an MRI. Next one, gag reflex, cranial nerves 9 and 10. The gag is assessed by putting things in the back of people's throat and seeing if they gag. And the neuro exam is cranial nerves 9 and 10, 9 and 10. And what's the most common reason to have an abnormality of a gag reflex? The most common reason for an abnormality of a gag reflex is a stroke. Abnormality of the gag reflex. Because the abnormal gag reflex, press on the back with that tongue blade, and that tells you whether you have a defect of cranial nerves 9 and 10. The pressure should be placed on the posterior third, where cranial nerve 9 and 10. Posterior. Anterior, no. It's okay to take pressure on the anterior because you don't aspirate it. When you lose a gag reflex, you aspirate, and that's very bad. Cranial nerves 9 and 10 that innervate the posterior third of the tongue. Cranial nerves 9 and 10. Posterior third of the tongue, cranial nerve 9 and 10 make you lose the gag reflex. In other words, I got drunk, I had a seizure, I'm generalized atrophy. I am drunk, I have a seizure, I have generalized atrophy. I temporarily lose my gag reflex. Next one, heel to shin. Heel to shin is the same fundamentally as a finger to nose, but instead of it being of the face, heel to shin is done with putting the patient's heel on their shin and pulling it up in a smooth motion. What do you see if there's an abnormality? Put the heel on the shin and pull it up in a smooth motion. That's cerebellar problem. Put the heel on the shin, pull it up in a smooth motion. The diagnosis, if there's an abnormality, is cerebellar disorder.
What I want you to do now is that I'm going to have you hold your leg out straight. I'll support it. And I want you to take this heel, and when I tell you, I want you to touch it on your knee, run it straight down your shin, and straight back up, and do it several times. So go ahead. Straight down. And now the other side. Switch side. Okay. Good.
So heel to shin involves the patient sitting, lying with your legs outstretched. It's a sign of cerebellar disorder. It's a sign of the same thing as abnormal finger to nose, and it needs an MRI and to be treated like a stroke. See, you should have normal one smooth motion with the heel on the shin. That normal one gives one single smooth muscle from the heel to the shin and the shin to the knee, back and forth, because it should be assessing smooth cerebellar function in one movement. The foot should slide down, okay, as it goes down the shin. Now, when you have an abnormal test of the heel to shin, it means, do you have the cerebellar defect, proprioception, or did you lose the dorsal columns? So there's either a cerebellar disorder or a loss of dorsal columns of the spine to be able to give you an abnormal finger to nose and heel to shin, because the abnormal heel to shin should be of something also of measuring of the lower extremities and lower down the spinal cord. Lower down the spinal cord is the heel to shin. Now, if there's a defect in the cord, if the defect is in the cord, when you open the eyes, it should correct, because you should be able to see what you're doing and fix it. Romberg, you have to close the eyes, because now I see I'm not getting my input from my proprioceptors. I'm not getting my input from my proprioceptors. Oh my goodness, I'm not getting the input from the proprioceptors. I can't feel it. Oh, now I feel it. But if you can't fix it by opening your eyes, if you can't fix this by opening your eyes, it means the problem's not in the cord. It means the problem is in the cerebellum. If you can't fix this by opening your eyes, the problem is not in the cord. The problem is in the cerebellum. See, the spinal posterior column rarely give a tremor, and they should correct the spinal column by opening your eyes. You know it's a spinal problem. If it doesn't correct when you open your eyes, it's a cerebellar problem. A hemiplegic gait is when you're paralyzed on one side and you've got to literally lift your body over. Hemiplegic gait, everything is weak on that side. Everything is weak on that side. And when hemiplegic gait is in the answer, it means that you've had a stroke, because one side of your body is paralyzed.
The gait that I'm going to demonstrate now is the hemiparetic gait. This gait, if we were to demonstrate it, we need to be able to show the extension of the leg and internal rotation. So the leg is too long. We get circumduction with the paretic side, but very importantly as well is that the upper extremity is very much involved, and so there's adduction of the shoulder, flexion of the elbow, pronation of the wrist, the thumb is tucked under, and a cortical fist. So this is the position of the hemiparetic gait. With the other side, being normal, having normal associative movements. You can actually hear the pattern of the gait as well as we have circumduction for the product side. Again, watching upper extremity postured into the decorticate posture. Lower extremity is actually circumducted, coming around.
Did you see how he had to pull himself, sort of like pulling one side of the body over? Like pulling one side of the body, hemiplegic? Because that's where you take a body that's very weak on one side and the other part tries to compensate for it. That hemiplegic gait. It's associated with extended leg, the foot, and plantar flexion. The extended leg with the foot and plantar flexion, pushing down, and circumduction of the leg. And the circumduction is where you try and flop it over. That's circumduction, going around in a circle. Circumduction, going around to try and find, let's pull it over. Let's pull it over. Circumduction of the leg. Because the leg is swinging outwards in a circular motion and the foot is dragging as it's scraping the floor because it's weak. It's dropped. The whole leg is weak. Oh, yowza, yowza, yowza. And the arm on the same side is bent at the elbow and close because when you have a stroke, the arm on that side tightens up. So you go, okay, let's flop it over. Let's flop it over. Flop it over. Hemiplegic gait. The arm is decorticate near the heart. Arm is decorticate near the heart. Arm is decorticate near the heart. I've had a stroke. My arm comes up here because it's tightening up. Okay, right leg weakness, okay? Stroke is over here and my arm is weaker and comes up towards the heart. Decorticate. CT scan is first for blood. MRI is most accurate because it's the brain. CT scan is best only for blood. The only thing for which the CT scan is superior is for blood. Everywhere else, the MRI is superior. The CT is superior only for bleeding. See you in the next section.